Thank you, the whale. Dr. Herman, happy birthday. Hey, Neil. How are you? Good, good, good. Well, the whale gave me this dry topic to speak at the end of the session. Not many pictures, but about 17 years back, we launched what we call the PERT. We don't have an official PERT program. In fact, the PERT programs really started in Mass General in about 2014 or 2015. So I'm going to just speak a little bit about what made it a success at Houston Methodist and Houston Methodist Sugar Land. So how to launch a PE response team that actually works, because there's no real criteria. There is some, but not real. No financial disclosures. We are part of the trials. Optimize, the high Python now going on, and the knockout PE that just finished. So we know that PE is not to be neglected because it's the third most common cause of death. And we have teams, STEMI teams, stroke teams, shock teams, but we don't have a PE team actually which works because there is no real data, there is no real consensus. There is some, but not everything. So one has to know that it's a humbling disease, and then you need to know how to stratify it. Now, the problem in managing a PERT team is that who stratifies it, So again, the objective is to provide a rapid, coordinated, and individualized care for the patients, which will produce good results. Now, that doesn't happen all the time. You just bang your head to try to, why is it so hard to standardize pulmonary embolism? It is hard because there is no real, absolute, randomized controlled trial and data, except for the patients who are dying. Then you have to do something, or who are really, really sick. So we are trying to get through the high Python trial that Boston Scientific is doing, and through the mechanical thrombectomy trial that the peerless study, a large volume of patients, and we are part of it too, to really identify what are those subset of patients that will benefit. Now, having said that, if you are a little bit more aggressive about treating acute PEs, about 10% of them will not go to the chronic stage, or even more. So there is a value because there is a lot of patients. But the problem in a PERT team is that there is a conundrum of specialties. And the training is different, the knowledge is different, and the skill set is different. So from pharmacy, the pulmonary critical care, many of them don't believe in what we are doing. So that's the problem. But the results of whatever we do is clearly evident in how the patient feels after the procedure, if it is a submassive or a massive PE. Now, whether you do mechanical or whether you do a thrombolytic therapy, that's an individual, that's a separate discussion. So the advantages is a faster diagnosis, but we get the diagnosis pretty quick, but the problem is they don't call you. They call you at the middle of the night, most of the time. That is the problem. So even though we have improved access to advanced therapies, supposedly reduced mortality, but actually the PERT consortium says that there is no reduction in mortality at all by having a big team. So it's all individual. So the ability to leverage multiple specialties and eliminate bias is what has been touted as the benefit of a PERT team. It sometimes happens, it sometimes doesn't. So the PERT teams have been shown to improve management of the PE patients, streamline the management rather, but it is not clear whether it has actually led to improved clinical outcomes. Because here it is, somebody will say, hey, it's a consensus opinion. It's not like STEMI, like primary PCI and things like that, or a stroke, you give one drug, TPA, within a certain amount of time. And this doesn't happen. In the middle of the night, nobody wants to get up and try to, hey, there's a PE here, and let's all come together and decide it doesn't work like that. So there are a lot of challenges, difficult to maintain a protocol, initial evaluation is inconsistent, and the interest and the support and the knowledge, most of the time there is a cardiology fellow or somebody who's actually looking at the patient first time and and then they start calling. So there is a delay. But if it is individualized, if there are certain people you trust, if they call you at a particular time, then you can actually achieve some results. This is what you don't want to do. You activate the whole PERT team in the middle of the night and then just demoralizes, and nobody gets paid for doing this anyway. So that's the real problem. So in patients with hemodynamic instability, right ventricular dysfunction, elevated cardiac markers, extensive clot burden, everybody knows what to do. So then what's the purpose of the PERT team? So the PERT team works very well in academic centers. We have a PERT team, but nobody gets paid for it, but they still go on. Most of the time, it's a very junior level person who comes and starts calling the attending and things like that. So I'm not really enthusiastic about a PERT team. It doesn't bring volume. That's one thing for sure. So in what has worked for me is people call, they know one or two people to call, they consult, and we basically decide what is going on. We have an OR always or a cath lab, and we get it done. Now, most of the time, you don't have to do anything. 50% of them don't need anything. The people who need, they get it, either a thrombolytic or a mechanical. Now, mechanical is, I have got my own views, but that's a separate topic. So the real thing is the communication is the key. Maintain good relationships with the ER, with the pulmonologist, and give talks and be part of trials, and people will understand that you're actually doing something better, or you're actually doing something good, and then you'll grow a volume. So that's what it is about PERT. And so you asked me to speak about a general topic. So that's where it is, and I'll be happy to answer any questions. I hope I'm 7 minutes into it.
I love it. You kept it short. Thank you very much. And entertaining, Dr. Tengudi.